Good evening. It looks like everyone is hopefully coming into the waiting room. We're probably going to make a start and just say hello. So I'm Therese, I'm one of the surgeons, and this is Jo.
Hi, everybody.
We are kicking off the autumnal INGS this evening and with a really exciting one on kissings. And I hope you guys enjoy it. So just briefly an intro to what we're talking about. So firstly, joined by Jo this evening. She is one of our orthopaedic surgeons here at the hospital, as well as myself. She studied at University of Liverpool with a real interest in surgery, especially colic surgery, which she did at MPhil on. She's recently presented at the European College of Veterinary Surgeons on a talk entitled "To Cut or Not to Cut." And so we thought we'd use that as an opportunity.
On kissing spines, not on colic. Yeah, so yeah, it was kissing spines to cut or not to cut, rather than colic to cut or not to cut.
No, not so appropriate then. So we thought it would be a good opportunity to sort of grill her and have a sort of a general discussion on treatment, diagnostics, and everything about kissing spine. So let's kick off. So I thought one of the first questions, and something I'm asked most of the time, Jo, is do you think this is a nature or nurture condition?
Well, so it's kind of interesting when I was looking at this for my talk. So there's a few studies that have looked at it in foals compared to a group of thoroughbreds in training, and they found that actually it was the same in the two groups, which would suggest that it's definitely more of a developmental etiology. So these horses have it from quite a young age, and I think that's where it starts to be really difficult to prize out the clinical significance of it.
So do you think sort of general screening x-rays of young horses is something we could enter into, considering if it's a developmental thing or not? Or
so there's a group that are actually now following it in foals from a really young age, and I met her at ECVS, and that's going to be really interesting data. But I think at the moment, the problem with screening X's is we see kissing spines or impinging dorsal spine fibrosis in about a third of clinically normal horses. So it's actually a surprising number when you look at the pathology studies and stuff, more in thoroughbreds. So if you look at a thoroughbred population, you're going to see it more than a warm blood population, for example. So if you just screen horses, you're going to see that in normal horses. So it's that, and that's where identifying the significance of this condition when you take an X-ray, I think is really, really tricky.
Yeah, no, definitely, definitely. So sort of going on to maybe diagnostics then, is there anything, obviously the scope of this evening is not, we can't go through everything, but are there key features of your diagnostic workup, both here at the hospital and also for people out on yard, so they can, what you'll take home and key points for those to try and eke out those differences?
So I think identifying lameness is really key. I think that's where, if we do surgery, that things don't work so well if the horse is also lame. And we've shown that. We did a big study, Therese and I did a big study here on our minimally invasive technique, and we found that there was a really good success rate in the majority of horses. But when we looked at the subgroup of horses that had other orthopedic issues, those horses didn't do so well. So rather than 80 to 90% returning to work, only sort of 50 to 60%. And there's a couple of other studies where around 30 to 40% of horses, having had either a desmotomy in one study or a subtotal ostectomy, 30 to 40% of horses were found to be lame after surgery. And so the lameness thing is crucial. And a horse that has hind limb lameness often will have back pain. So I think that's one of my key things, is having a really good look at a horse in a straight line, on a hard lunge and on a soft lunge, to see if, and maybe the two things are concurrent, but actually that would be one of my, for me, I need to have that knowledge before I do surgery.
Yeah. And do you feel that that's sort of essential to have sort of addressed and sorted? So do you feel that that's sort of a no-go if a horse is still lame? Will you still operate on them? Is that something, or?
To be honest, it does depend on the owner. So sometimes we have owners that are obsessed with kissings and come very much kind of lined up for surgery. And so those, I think I would tend to try and address the lameness concurrently. I think the other thing is obviously the rehab program post-surgery is super important, but it's actually relatively hard work for the horse, doing quite a lot of lunging, long reining, pole work, and so the horse has got to be of a level of soundness that it can manage that and manage the rehab program. But it doesn't mean that you can't do surgery on the back, and at the same time, well, not immediately at the same time, we wouldn't advise that, but like a few weeks later, medicate the hocks, medicate the neck, try and get it such that when the horse starts its rehab program, you have the horse as comfortable as possible, because that's the key is with the back, is if the back is comfortable, they're going to use themselves properly, they're going to develop those muscles, and they're going to be more comfortable. So it's about getting the whole horse comfortable.
No, great. When you're palpating backs, do you mind just talking us through what you do? Have you got sort of a routine that you do? And are there any sort of tips and tricks?
Yeah. I mean, I sort of start from a slightly broader than backs, in that in my poor performance stroke, I think my horse's back pain thing, I will start with actually the strap muscles in the neck. So if they're tense on palpation, I often find that can be correlated with bilateral forelimb lameness. And I will also do neck flexions, because I think that neck pain in some cases can present like back pain. So I guess that's part of my back assessment, I guess, is those two things. And then I will palpate along the dorsal spinous processes themselves, and then I'll palpate and I'll change sides. I do it both the apaxial musculature from the opposite side all along, and then the other side, and then I'll also palpate the sternum to look at lift, and I'm looking at that muscle spasm, evidence of pain, evidence of lack of dorsal-ventral flexion, and then I'll also palpate over the gluteal region and the sacroiliac region as well.
Yeah. So like a really thorough palpation. And do you find horses that you would say have got more significant kissing spines will respond more to direct palpation, or no?
Although actually someone at Beaver recently, I did the back session at Beaver, and there was quite a difference between, I don't think it mind to say that Andy's section, and there was a European lady whose name I can't remember, I'm afraid, but she was like, oh yeah, my back palpation is really key, and Andy was more along the lines of like me, that lameness can cause back pain. And I think if it's there, it's clinically relevant, but I think I wouldn't like hang my hat on the fact that the way I palpate a back means I know what I'm going to find.
Yeah, no, definitely.
One of the things actually, I should go back, that I'm probably sometimes not the best at doing, but I think we should do, is considering saddle fit. And to be honest, that often for me is, have you had a saddler look at your horse's back, rather than me actually going, oh, could you show me your saddle, and pronounce that I'm some sort of saddle expert. But I do think it's something that maybe occasionally I fall down on, and sometimes also, if you don't, we sometimes don't always meet the rider, or sometimes gets dropped off, and then if you actually see a rider ride a horse, you can gain loads on the way they ride, the way that they fit their saddle, and their saddle fits them and the horse. So I do think that that's something that maybe I could do better.
And as part of a workup here at the hospital, do you normally, as part of a back pain workup, would you normally routinely request the rider to watch a horse ridden? Or
so I have someone volunteered to ride for me once, and they broke their shoulder, and it was all very dramatic, and we had they went off in an ambulance. So I am cautious about it if they've got any concerns, but if they're willing to, and they say, oh no, the horse doesn't bark, but I am aware that I'm asking them, if it particularly depends on when the horse was last ridden, so I'll always ask them that, because if the horse hasn't been ridden for a month, they get on and they get decked, then I feel responsible. So I am cautious from a safety point of view, but I do think it can be really useful to see that horse ridden. We do have a rider here who's really great, but again, I don't want to put her safety at risk, but she's ridden at 4-star level, so and she's really light and tiny, and so I think we sometimes use her for our crash test dummy, Sarah, and use her for blocking and things. But I think there is a element of being slightly cautious about safety.
Yeah. Were you saying the RVC have a weighted?
Yeah, they do. I was talking to Andy. They use a weighted, like it's sort of like a big weighted roller that they've developed, and I think there's probably pros and cons to it. But I'm gonna see how they do that, because I think that might be an interesting thing to allow you to use that for blocking in a safer fashion.
Yeah. Oh, great. Right. So still on to X-rays. I think this is something that we're sort of routinely doing more and more. So are there any sort of take homes you want to talk about, or discussion points for taking X-rays firstly out on the road? What are we looking for, et cetera, what do you think?
So I think we want to make sure that we take as good quality X-rays as possible. To be honest, is where I have lovely Ant and Hazel, who take my X-rays for me and take much better X-rays than me. But I think you want to make sure, so it's important to be aware that the horse's head position can affect your degree of impingement. So having the horse with a neutral head position can affect your degree of impingement, and then also the distance of your plate from your horse. So I think having a plate in a stand, and also bigger is not necessarily better, like with many things. So making sure that you collimate quite tightly will get better quality radiographs. So I think that those are all things. And I think also being sort of discussing with the client the ability of a DR to get good quality images. And if you click onto the next slide, Therese, there's an image that we took out of the DR out on the road, and then the image of the articular process joints that we get in the sort of the caudal thoracic region in the hospital. And I think there is a difference in quality. And so we do routinely include in the price of surgery radiographs of the vertebral bodies to check for vertebral body spondylosis, and to look at the articular process joints. You can see here the two most caudal ones are really quite enlarged. And so I think, actually, to be honest, I think ultrasonography is probably even more sensitive than radiography of the articular process joints. And there's been a recent study that's looked at CT versus ultrasound and actually found pretty good correlation. So if we're looking for OA of the articular process joints and we want to treat that concurrently, so medicate those joints at maybe the same time as surgery, or make a client aware that the horse has those at the same time as surgery, I think that I would maybe employ ultrasound as well. I think also with all of these things, it's quite hard to know what's significant or not. So the same with vertebral body spondylosis. But I think we would all feel, and we're actually doing a study on at the moment, that we see more cases of vertebral body spondylosis in horses that have numerous kissing spines.
Do you think that's them just trying to fuse their whole spine, or no?
Whether there's reduction in dorsal ventral flexion and the way that they use their back, I don't know. The way that we're doing the studies, we've got some horses that just had thoracic radiographs. That's our control group, and we're looking at those compared to horses with back pain. So I think that's going to be quite an interesting thing. But it is hard when you see vertebral body spondylosis on a horse you're about to operate on. You have to tell the client, but it's then what level of significance do you place on that? We do also see some that are quite hot on bone scan. Yeah. But again, what does that actually mean is sometimes hard to tease out.
I mean, my dog had thoracic radiographs relatively recently, has a couple of sites of spondylosis, but currently has no signs of back pain, my dog. So yeah, it's funny because also in people, sometimes spondylosis isn't associated with pain, but maybe because we're asking our horses to dorsal ventral flex more commonly, maybe it is a more restrictive disease process. But yeah, who knows? Yeah. I think this was a really interesting slide. So yeah, this one of our sort of technique of how we do it here at the hospital, we put all of our horses on a headstand to try and level out the head position, and then we use the positioning, we use the flooring on the matting, this line in the flooring that we basically put the horse's foot either side to try and sort of standardize distance to try and help, which again is obviously really hard to replicate out on the road, but I think it's just having a appreciation of those thoughts about plate distance, and
definitely, and not having like the handler on their phone.
Yeah.
Not concentrating and not on the kind of sending a WhatsApp message or whatever. Like I think actually when you have the horse genuinely straight, you get better quality images.
Yeah, and I commonly find that people have used stands, which I know is a bit of a faff to put in the car, but obviously ideally would be using for aviation safety, but people who've used stands both for the plate and for the X-ray machine tend to have slightly better quality images because they're not fatigued from holding up this X-ray, trying to take multiple shots of this horse's back. So I don't know whether you think that's something. So on to severity, which I think is a really important topic. So first I just want to ask, do you routinely grade these? Do you have a grading system that you use, or do you just go subjectively?
I probably describe what I see in my reports. I'll say that there's 8 sides of impingement ranging from T14 to L2, and I'll say if there's for the presence of lysis or sclerosis. But I think there's enough studies that show that there isn't potentially great correlation between severity and back pain. And I think that's why there's a really nice recent review paper looking at whether radiographs of the thoracolumbar spine should be part of a pre-purchase exam, which is a bit of a thorny subject. But I think that they highlight quite nicely numerous papers where there's not perfect correlation between severity. So then I don't get too hung up with grading it, because I think there's so many, it doesn't really mean very much. I think the fact that they're there, you want to make comment on that. I think where I would include them on a pre-purchase exam is where I've got an owner that's maybe had a previous problem with it. So they're going to be much more averse to risk associated with this area, and I guess they might be more annoyed with me if I haven't seen them. So I think that's where being a bit aware of your client, and absolutely if a horse presents clinical signs of back pain, so then I think that, but actually I've had one horse, it was a 4-star eventer that I vetted, it just had a very slight tail switch, it had an excellent record, and its back looked awful on radiography, but its record is brilliant, and it's really then hard to know what to say. And the only thing I think that I would say that is relevant in those cases, if you have a change in, often we'll see cases becoming a problem when we have a change in training, rider, saddle, and that's where that can kind of maybe needs to be highlighted to the new people that this horse could have a problem because of the basis of what the back looks like on radiography. But I think there are definitely limitations.
Yeah. And I mean, obviously we spoke briefly about the fact that whether we think this is developmental or not. Can you tell, are there any signs that you're looking for in the x-rays to say, well, actually, I think, this horse's recent change in behavior, the back pain we're seeing now, I think is now to do with this horse that's probably had kissing spines for a while, but how do you sort of interpret x-rays in light of that? Do you think other specific things you're looking for in those x-rays?
I suppose I get a little bit more excited if there's quite significant sclerosis and lysis.
Yeah.
But I think other than that, not really. I think you can see if horses have had a desmotomy before. So I think, and definitely, and we're going to touch on it later, actually, horses that have had any sort of surgery, I think you can see that on radiography. But I think not really, just from the point of view of kind of how recent these changes are.
Yeah. I think it's a really hard conversation to have with owners because, yes, as you just said, maybe it's changed at hands and then the horse is now, decking its rider. And probably some of these findings have been there for a while, but maybe it's the fact that it's had, the summer off, lost all its muscle, lost its ability to cope, and now, or a change in rider skill, etc., and then it's a problem. So really hard to interpret. I think briefly, there's a image here trying to talk about scintigraphy. What are your thoughts on scintigraphy and bone scan? How would this influence how you might treat a horse, or what do you think?
I think sometimes we do, if they're active on bone scan, we do, that does add a little bit of weight. I think we definitely bone scan horses quite a long time after surgery, and they're still hot, even though the horse is doing really, really well. I think the other useful thing about scintigraphy can be that sometimes it'll highlight other areas to look at, like the SI but I don't think scintigraphy is a brilliant screening tool, if I'm honest. And I think sometimes these horses are actually just horses that are difficult to block, difficult to do things with, and that's where scintigraphy can allow you to make a step forward from a diagnostic point of view. And you can see if it's got vertebral body spondylosis because you get hot areas there. I think there's a few pictures a bit further on of different and articular joint pathology, and there is a correlation between articular process joint pathology that's hot on scintigraphy and the presence of dorsal spinous process. There's a paper by Sue Dyson that shows that correlation, but I think that I wouldn't hang my hat just because it was hot on scintigraphy that it was definitely a clinical problem.
And so no sort of strong evidence that it's hotter on bone scan, therefore this is more of a problem, or
no, not particularly, no.
And or that hotter on bone scan are going to see worse x-rays, or nothing?
I think if it's hotter on bone scan, you do tend to see definitely when we radiograph horses post bone scan, if it's really hot on bone scan, you're going to see lysis and sclerosis. So I do think that those two things do correlate.
Fab. I think we are on to some of the neuroanatomy sort of.
This paper, so this was quite interesting, I thought. So this paper looked at whether there was a difference in the nociceptive fibres between a group of horses that had ODSP surgery and a whole group of horses that didn't, and they didn't have particularly good correlation between the two. And they wondered whether that's why some horses show more signs of pain and some don't, because of actually a difference in the upregulation of nociceptive fibres.
So the population of horses that had back surgery that perceived may have had more back pain had more pain.
No, they didn't. There was no difference. There was a lack of correlation, and so it's whether that whether that has whether the percentage of whether that upregulation of nociceptive fibers is significant or not.
Oh, I think this was a couple of just examples that we wanted to put in just to highlight some of the other things that we can see. So we've got a really lovely example that I think was really hot on scintigraphy, this one, of a spondylosis in sort of multiple sites of spondylosis in this horse that again had signs of back pain, was having back x-rays for that reason. Again, another example of sort of the articular process joint changes that we can see sometimes with concurrent articular DSP changes. And I think then this was just a reminder to talk about necks a bit more, and this horse with a hideous osteoarthritis of C6, C7 at the base of the neck. And I suppose we touched a bit on that with our clinical exam, but I think we're very much considering our improvement in diagnostics of the neck. We definitely will check that pre-surgery now, when we will sort of, it's one of our, does this horse have any signs of neck restriction as well? And again, the final one at the bottom right is just some ultrasound images of a horse with articular process joint pathology on ultrasound scan, which again, we are doing more routinely now. I think it's a generally sort of more widely used modality.
Occasionally the neck, a bit like everything, you can kind of sometimes get yourself, I don't know if you've found it, into slightly muddy water. So when you radiograph the base of the neck of a middle-aged horse, and not like this one, obviously this has got like stonking pathology, but it maybe has some enlargement, and you say to the owner, well, your horse has got some enlargement of C6-7 articular process joint, which may or may not be significant in a horse of this age. And I think that's where, again, it can be a little bit murky. But I think if you've got that with clinical signs and the horse is presenting with neck pain either on flexion or ridden, we've now got the ability to CT them as well. So I think that's where at least looking, but being cognizant that that will be normal in some middle-aged horses.
Oh yeah, no, 100%. I think they must have spoken this about in the wobbling session that happened last year as well. The clinical exams, everything really, isn't it? But yeah, no, that's great. This was just to highlight that I think ultrasound is being used more and more, and that actually CT, as you said, has really good correlation with ultrasound. And again, are there any horses that are you routinely, if you see an enlargement of the articular process joints, do you always recommend ultrasound scan, or are you happy that you've seen enough on X-ray, or do you?
I think if you're concerned about them, then I think you want to ultrasound scan them.
Yeah. And I had one recently that was quite interesting, that had quite lateralization, so one side was much larger and more irregular than the other side, and actually interestingly fitted with the clinical signs of the horse. So we've actually elected only to medicate one side all the way along, because obviously X-ray is obviously a 2D image of the 3D structure, but the ultrasound at least helps you lateralize a little bit more. Okay, on to blocking. So do you block?
Yes, if I can. So if I can get a horse that so I think there's several things. One, obviously talked about safety. Secondly, is consistency of clinical signs. So I want to always watch the horse ridden here to check that I can see something that both me and the rider can see as a definite thing that we can block. So something either consistent tail swishing, consistent reluctance to go forward. I think if you video here, it's quite nice before and after. So I do like it, but I do think it's again there are some things to be aware of. So you can definitely block a myopathy, which I have done. I've also, to be honest, done surgery on a horse with a myopathy that then progressed and got worse, and we looked into it. And I think, it's amazing. You can do muscle enzymes, they're only just very slightly elevated. And so I think this is a tricky area, but you can definitely block the muscles rather than the back itself. And I think the other thing to be aware of is even in a normal horse, blocking the back will improve the dorsal and ventral flexion.
So you have a false positive, basically.
So we can definitely get false positives. And there is a paper that they looked at whether blocking the back was correlated with better outcomes following surgery, and in the Brown paper it was. So if you had a positive block, the horse was more likely to do better after surgery. So I think that does highlight that you're in the right bit of the horse, and it's not bilaterally behind the lame or something. So I think that's important. When it doesn't block, again, I think that can be slightly tricky in that might just be because that horse has a particular pain threshold, or are you actually blocking the relevant part. And I think our knowledge of the neuroanatomy of the back is quite limited. There's quite a nice review paper, if you're into neuroanatomy. So if you want to go to sleep quicker tonight, you could read the Deering paper, which kind of discusses the neuroanatomy. And they did that on the back of the fact that after desmotomies in a load of horses, they have this weird area in a few horses of muscle loss of the longissimus muscle. Having gone back from that to the neuroanatomy, they found that they transected the intermediate branch of the dorsal spinal nerve, which, to be honest, I had to look up where it was. But I think it's interesting that actually we block back loads, but actually our knowledge of the neuroanatomy, we do surgery on their back loads and we cut loads of nerves. And there's quite a big group of surgeons, and I sort of think I'd be one of them that sort of feels that in some respects you're doing a neurectomy, particularly with the desmotomy. Because you're not, without genuinely impinging, you can't get your blades between the processes, and so maybe what you're doing is cutting the nerves.
Yeah. And out of interest, what technique do you use, and how much local anaesthetic do you use, and how long do you wait and stuff?
To say, I do both sides of the processes. There's a recent paper that this paper looked, and they suggest that it's much more accurate just to put one needle at the space. I do think actually you should take an X-ray when you block them. So because we do this quite a lot, we use radiographic markers when we do surgery, and you can feel the indentation. You stick your spinal needle there, and then the radiographer takes an image, they're like, oh no, you're in the wrong place again, Joe. So I think it's important particularly if there's a lot of impingement, actually, that's almost where it's harder to feel where the potential gap should be. So I do it radiographically guided, but I do go biaxially, despite this recent paper, because I find it really hard to get a needle in between the impinging exposed processes, and then if I do get it in there, trying to inject into a solid mass of tissue, my 5 mils or 10 mils or whatever it is, it just spurts back in my face, and it's deeply frustrating. So I kind of block back thinking, I'm probably blocking quite a lot of this back, but at least I know it's back and not behind and lameness, and I know that I'm getting a significant improvement. But I have to say, despite this paper, I haven't changed to the single needle technique.
No, and do you, out of interest, what needle do you use? Do you use 18 gauge spinal needle?
An 18 gauge, yes. Yeah.
I've sort of switched down to the 2-inch little 19 gauge ones, just because I find them slightly easier to ram in. But again, I do the 2-needle approach to both sides rather than the midline approach for the same reasons. And out of interest, how much local are you using?
About 5 mils both sides.
5 mils both sides, yeah.
I used to use more.
Yeah.
But having read this paper, I decided I should maybe be a bit more conservative. But yeah.
Yeah, I think this paper really nicely highlights. You just got the images of the technique at the top, so the midline on the left, the 2 spinal needles in the middle, and then I think this is the contralateral approach, and then just the blue dye showing where the local anaesthetic went in these cross sections, which I thought was just quite interesting. And consistently with the midline approach, they had a more accurate anaesthetic. And then how long after blocking do you watch them?
Once they've woken up from xylazine. So they basically, I'll ride them, or not, I won't ride them, I have done that once as well, but I will get someone to ride the horse, I will sedate them with some xylazine often, and then I will put blebs in actually, and I'll block them. I mean, really good horses, you can probably just do it with blebs, but often these horses are really sensitive, and really, so I think, and then so it's, maybe then give them 10 minutes, walk them around the hospital, and make sure I'm happy that they're not sedated before I get a rider back on board.
Great. So we've talked about scintigraphy a bit. I think this just highlights some of the images. Yes, this is a horse that had the spondylosis, which was the radiographs we saw on one of the previous images, just for interest.
I think one of the things to say here, actually, not of the back, but of the hind limbs and pelvis, we can now CT the pelvis. And I had a case of the day that didn't block to, well, it blocked him partially to a deep branch of the lateral plantar nerve, and then I went up its leg and I couldn't abolish the lameness, and I still had a significant degree of lameness, and that had a CT of it, pelvis and hind limbs, which was really, really helpful. And so I think that if we are concerned about the sacroiliac region or hind limb lameness in an unblockable horse, I might now go for CT rather than scintigraphy, because I think it just gives you so much more information.
I suppose apart from the anaesthetic, which obviously is the main downside, I suppose it's cheaper as well, really, isn't it? So it's only about 1,500-ish plus VAT. So yeah, I suppose it saves the owner a little bit of money as well, but obviously have the anaesthetic risk component.
And I can't take any credit for this, but they're getting even better at getting big fat horses through it.
Yeah, and I suppose this is onto it now. So I think obviously this is Nadine's child, I would say, and her enthusiasm. So yeah, I mean, I think this was a recent case that she had that had quite marked OA and bone changes at its SI joint. And I think it's something we are doing more and more, and just getting referrals for this as well, aren't we now, really? But actually does add to our workup probably. And
I think the problem is that you can't CT every horse's
no.
pelvis, and that's where it's really hard. Like, I think that we get more and more diagnostic capability, but then you're like, oh, which cases do I use that in? And that's often budget and practicality. But I think it's there as an option now, isn't it? Which it didn't used to be. And I think the other thing is that now trying to ascertain what findings are significant as well, I think it's a learning process. But I think if it's unilateral rather than bilateral, I think we would place more significance of it. But there's quite a lot of evidence that quite a lot of horses will have abnormalities, as people do, in their lower back, without necessarily causing clinical significance.
So I think we've got just a couple of cases just to talk about before we go on to the actual surgical techniques. So Jo, do you want to run us through this one?
Yeah, so this was a 6-year-old mare that had a reluctance to go forwards and unwillingness to go an upward transition to canter. Like lots of these horses, it had gastroscopy, which had no significant evidence of ulceration. The radiography of the back by the referring veterinary surgeon revealed impinging dorsal spinous process. So the horse had its back medicated and did show a temporary improvement. So it was referred to us for further investigation and potential surgery. So the horse was sound, but it lacked impulsion, and when you watched it go, it just was really sort of restricted in its movement and was sore on thoracolumbar palpation. And ultrasound of the articular process joints was normal, and so I decided just to do a resting CK and AST, which were mildly elevated, and then I did an exercising test and looked at them again 6 hours later, and they were slightly more elevated. And so we did a muscle biopsy, and the horse had a myopathy. So I think it's just a reminder. And I think sometimes, to be honest, we don't think about. I've definitely in the past not thought about this enough, and it's really hard to know. And also, I guess the other thing to be aware of is that the CK and ST are not always elevated in horses with a myopathy. So again, but I think it's just an interesting case and something that we're aware it does happen.
Yeah, I think we're going to do an Ings on musclings at some point, so we can hopefully go into a bit more detail. But just for everyone, how long after the initial bloods and exercise? How long do you exercise them for? Just out of interest.
So generally, actually, I use my assessment but my assessment would generally take about 20 minutes. By the time the horses lunge on the hard and soft and canted on both reins and whatever, so around 20 minutes, maybe half an hour of exercise, and then I would take the second load of blood 4 to 6 hours later.
Yeah, and just out of interest, elevation-wise, I know sort of how long is a piece of string.
Relatively mild elevation can be significant. Yeah.
Cool. I think this was. We've sort of spoken a little bit more about this already, haven't we? In terms of the lame horse.
This pony was quite interesting. So the jumping pony that had muscle spasm on its thoracolumbar region, a mild bilateral hind lameness, and then so I blocked it, and it became, other than bilaterally hind and lame, it became much more unilaterally hind and lame. So we radiographed its back and its hocks, and it had evidence of osteoarthritis of the distal intertarsal joint. But then also on radiography of its back, of its articular process joints, it actually, if you move on to the next slide, Therese, it had a fractured rib.
Oh wow!
Just there you can see, and it also looked like it had some enlargement of its articular process joints, which were really unilaterally irregular and enlarged on one side. So rather than doing impinging dorsal spinous process surgery, I actually medicated its hocks medicated tartic process joints, put it on some bute, and we actually retired it from show jumping as well. And it became a hack success story. But yeah, I think it was a case where you can see that multiple things can contribute.
So we're probably getting onto the sort of business of things, talking about different treatment options. So yeah, do you want to talk us through some recent literature on it?
Oh yes, so this paper I thought was quite funny actually, because it basically looked at who did what, and basically if you're Irish or English or American, you're more likely to do surgery, and if you're from the continent, you're much less likely to do surgery. And unsurprisingly, if you're a surgeon, you're more likely to do surgery. But if you're a sports medic, you're just going to stick some steroids everywhere and not do surgery at all. So I think the paper really dramatically highlighted that amongst a huge group of specialists, there were really different approaches to impinging dorsal spinous processes. So who knows?
Looking at medical management, what do you class as medical management? What drugs might you use?
So obviously medicating the back with steroids, definitely. I think having a horse on some bute. I think what we're trying to do is get the back comfortable so the horse can exercise and use its back properly to develop its back, increase its cross-sectional area of its multifidus muscle, which has been shown in people and in horses to be correlated with pain if that cross-sectional area is reduced. Definitely rehab is key. And this paper from EBE, which does have various kind of study issues with it because there is recall bias and selection bias, but they showed that horses that had a proper rehab program were 10 times more likely to return to work than horses that didn't have a proper rehab program.
And what do you mean by proper rehab? What sort of things would be incorporated within that, and how long do you give these horses off, and is it all non-ridden and stuff?
It depends a bit on why the horses. If you're trying to eke the season out, the horse obviously doesn't have so long off. Whereas if you've got a horse that's got a painful back and you're trying to rehab it over a longer term period, I would tend to start with 6 weeks. And that would be with we're going to touch, I think, in a few slides, but with some exercises, nose to floor, nose to girth, both sides, stretching and flexing exercises, physiotherapy, and they've shown that actually is correlated. Doing those exercises repeatedly will increase the cross-sectional areas of multifidus muscle. So that's definitely that on the floor physio. And then the horse not being ridden. So lunging, long reining, so fitness development, not all on a circle, some in a straight line, but lunging, long reining, being led from another horse as a combination, using it itself properly will potentially help. And then I think probably in the future, shockwave. That doesn't actually been shown. It doesn't actually affect the cross-sectional areas of multifidus muscle, but it does reduce muscle pain. And so then if the horse is more comfortable, it's going to be able to work better. And that's the same with actually using, I don't use it that much, but Nadine has started us using it a bit more, I think, is ribaxin, which it's off license, but it can reduce muscle spasm, and it's used sometimes in people with back pain. And then I don't actually use this, but when I was researching for the talk I did at ECVS, neuromuscular electrical stimulation has been shown to increase the cross-sectional areas of multifidus muscle, and so I think can be a useful adjunct. Interestingly, there's very little evidence for acupuncture when you try and tease it out, but I guess if it's making the horse more comfortable, then that will have a similar, positive effect, and also the owners like it, so that's good.
Yeah, I've had quite good effects with TENS. I think you can get them off Amazon, and for both neck pain and for back pain, I found them really, really useful, and apparently loads of horses absolutely love it to sort of go to sleep whilst they're on, if they're quite relaxed. And any thoughts on sort of training aids at all? Do you like psoas, bands, anything like this, or what?
I think it depends a bit on the owner's ability as well. So some owners are really comfortable lunging and long reining and are able to manage a horse in a psoa. Other owners may find the psoa a bit more challenging, and their neck band is useful. I think you don't want the horse too restricted. I think it's important that it has some freedom of movement through its neck. I don't think you want it absolutely pinned in as well.
I mean, I sometimes when I use the ribaxin, which you talked about, which is methocarbamol for some people who maybe not be so familiar with it. I'm not sure about you, Joe, but I use it for the cases that haven't responded as well as I would like to with medical management. It's sort of the first line, and then they may bring up being like, I've only had a partial improvement or something. I need to sort of go for the big guns a little bit more. And then that's probably maybe when I use it a little bit more. I don't know if that's sort of similar to you at all. But again, it's not licensed for horses, but again, it's used quite.
I think it's the training video here, I think reminds me is that also sometimes having a professional, this is not a professional for me actually, it's slightly embarrassing.
We'll play the video just to see.
Not a professional at all. But I think that having somebody who, because sometimes I think that one of the things that can make a difference when we do surgery is a horse goes to a professional rider and gets bitten well, and that can really help the horse develop muscle. And so I think that, and also, to be honest, if I've fallen off my horse, I'm a bit more reticent about asking it to go forwards. Like you think, oh, am I about to get decked again? Whereas having a profession involved, either at this point or post-operatively, post-surgery, I think can be really helpful in breaking that sort of cycle that can kind of occur.
Yeah, no, definitely. And people seem to be more committed once they've had surgery. I feel people are more committed to surgery, to a rehab.
To all of this rehab, like once they've had the surgery, and I think that's one of the things that surgery gains is that commitment to a proper rehab process.
So maybe we could try a sham operation.
Yes, I think we might get struck off if we start to. Yeah, not sure that's a good idea.
We've spoken about the shockwave just helping reduce pain rather than actually helping muscles sort of development, and we cool. Then on to sort of when to cut.
Well, I think it's tricky. I think if I've ruled or if I've acknowledged the potential for other sides of pain, so it doesn't necessarily mean I've totally ruled it out, but I've kind of considered it. I think if ideally that the horse has responded to medical management maybe for a little bit or has had a positive block is also helpful. I think in an ideal world, I'd feel more comfortable if we'd at least tried medical management and it had failed, but I recognise that definitely doesn't always happen, and sometimes people just want to have the surgery. So that definitely is also the case. We've kind of touched on this actually already, I think.
So we're now sort of onto the different techniques that you can do. So we've now decided we're going to operate on the horse. So which technique do you do, and what sort of success rates do you sort of consider?
So we do something called a minimally invasive cranial ostectomy, and to be honest, when you look at all the papers, so this is sort of this table kind of goes through the various techniques from a total ostectomy, which is the historic one where they just take the whole process out, and through to interspinous ligament desmotomy. About 80% of horses get better whatever technique you use. Essentially, there are obviously some nuances to that, and I think it also depends on exactly what you do with the horse. So, for example, the Deering paper, the horses were not only they obviously were athletes, but they were running in straight lines, and I think that's quite different than asking a horse to use its back on the flat, and I think that is a difference. But around 80% of horses will improve following the surgery, which is, as surgery goes, that's really good. That's pretty good for good for what we do.
Are there any papers looking at sort of medical management and success rates, just out of interest, or is there anything?
Not really. There's not a really nice randomized controlled trial between the two. There's just this one EVE paper which does sort of try, but it's based on owners' responses. So the owners that say that they had surgery say they did better, but that's because they're committed to the surgery. And it also depends on who actually participated in the questionnaire. So yes, I guess that paper would suggest that surgery was better, but there's not a nice randomized controlled trial. I think what you can take away though is that most horses will get better, which I think is positive.
So I thought we'd just quickly go through some of the different techniques there are. Do you want to talk us through what's going on here, Jo?
Yeah, so this is an interspinous ligament desmotomy. So you make a small incision, having taken a radiograph with a staple or whatever, or a spinal needle, and then you make a paramedial incision about 3 centimeters from midline, make a little tunnel under your supraspinous ligament, and then use a tenotomy knife, which you can see here, and you can take a radiograph with the tenotomy knife in place to transect your interspinous ligament. So yeah, which you can see, that is a tunnel being made here. and then the tenotomy knife going in, and then cutting the ligament. And I think this technique has small incisions, which is great. And I think you can get the horse back to work pretty quickly. I think what's really difficult is if the processes are really impinging, you just can't get a knife between them. So I think then probably you're wafting it adjacent to it. So I think it's not a technique because of that I would do that much. Some people use it in combination with a subtotal ostectomy, and so do some sites like this and some with a subtotal ostectomy, but that's this technique.
And then we're on to a minimally invasive craniostectomy.
Yeah, so this is a technique that was developed here at B&W, and basically what we do is we make little radiographically guided little 1.5 to 2 centimeter incisions over the cranial aspect of the site of impingement, and then we use a periosteal elevator to dissect between the process and the surrounding soft tissues, and then we use bone rongeurs to nibble away the cranial aspect of the process. And
you end up cutting we sort of end up cutting the ligament as well a little bit there as well.
Yeah.
So it's sort of combined.
It's a kind of combined.
Yeah.
So, and I think it, for me, but obviously I'm biased because we do it here, but it kind of gives you the best of both worlds in that you do definitely transect the ligament, and you do create a space between the processes, but it's through a small incision. So I think that and actually, you know, that means that the horse can return to work better. There's less of a concern about infection and stuff. So for me, this is a technique that I use.
These are some pre and post-op radiographs. You can see the two sort of spinal needles in, sort of localizing where the sites are, and then the post-operative images showing the bone resection afterwards. Do you find this technique harder when the process is sort of impacted the whole way down?
I think.
Would you change your technique based on that at all, or?
I think it's where it's really key to have the right rongeurs. So we've definitely had some people that have asked us for our dimensions of our rongeurs, because if you've got the wrong rongeurs, what happens is that they either are too big and they don't fit through your small hole, or if they're too small, they don't open enough. And with the and then it can be hard to actually open them over particularly with impacted bone, there's more bone. I think the other thing that can happen where it's really impacted is it's harder to, mostly you can sort of slide quite nicely down the cranial aspect, and then you pop your finger in, you can feel the smooth caudal edge of the cranial process. But sometimes where they're really impacted, you take a nibble and it kind of comes off a bit of both.
Yeah. Is that an issue, do you think, or no?
I don't think so, no. And then this is a subtotal ostectomy, which, to be honest, is one of the, I think, more common procedures for when people remove the cranial aspect of the dorsal spinous process, either done with an oscillating stalk or an osteotome through a single incision. It definitely gives you better visibility. I think horses are more painful following this. This is how they did it when I was a resident. Yeah.
I think they get quite nice post-surgical images. I think for that sharp osteotome, either an oscillating saw or whatever, they get really nice sharp images rather than sort of the nibbles off.
Yeah,
the nibbles off.
Slightly mossy nibble.
Yeah.
Well, this paper actually recently, so we've always been really focused on taking the cranial aspect of the process, and the group from Liverpool kind of looked into whether that was the best thing to do. And I think it's always quite good to kind of relook at a sort of dogma and say, is this the best thing to do? And so what they found which actually, to be honest, in our technique, I think is less relevant. But when you've got a caudally inclined process, what can happen is you can produce what's called a never-ending cut. So if you take that cranial process out, you can just keep on going. And there are complications that have been reported associated with that, particularly with an oscillating saw, but I think you can also do that with an osteotome. So they proposed that taking the caudal aspect of a process would reduce the risk of that, and they also showed that actually taking the caudal aspect of the process might reduce the amount of bone removed. So I think what I took from it is that I was going to do a little bit, it maybe made me feel a bit more relaxed if I ended up taking the caudal rather than the cranial aspect of the process. I think they're going to start maybe doing it in some clinical cases now. So this was just an in vitro study, or an ex vivo study, sorry. So I think it's just interesting that people are looking at this and how we're best to do it.
So I think this one was looking at post-operative sort of monitoring. So can we look at anything post-operatively to monitor horses' progress sort of objectively?
So people have looked at the multifidus muscle. There's not really great studies with lots of numbers. So they are kind of, but they have shown that post-operatively there is potentially an increase in the cross-sectional area of the multifidus muscle. There was quite an interesting CT paper in cadavers, so an ex vivo paper, where they looked at interspinous ligament desmotomy and subtotal ostectomy, and they compared how that affected the movement of the back, and they actually found that it didn't improve, and that no technique improved the dorsal-ventral flexion or the lateral flexion, but did increase the rotation of the back. So, and they also showed that interspinous ligament desmotomy, where you come across, always damaged the multifidus muscle, which I kind of thought was interesting, because I guess we're trying to protect that muscle. But as I say, it was an ex vivo study, but it was starting to try and look at the biomechanics of how surgery impacts back movement.
And do you think there's any cases where it sort of really reduces stability? Do you think by sort of, obviously sometimes with kissing spine we almost think the back is becoming sort of more fused? Do you think by removing some of that bone are we creating sort of instability? What do you think about that? Or
I don't think necessarily creating instability. I have had a couple of cases that have had come for ostectomy following interspinous ligament desmotomy, and they definitely had more new bone. But I personally don't think that they create instability. This was quite an interesting point at Beaver, and there was one lady that definitely did think that it created more instability. I guess from this paper, although ex vivo suggests that the only instability potentially is rotational, but not others. But obviously this isn't in a live horse, so I think probably there's more work to be done to look at the impact of it.
complication time, every surgeon's dream.
Well, back surgery actually is kind of relaxing, I think, compared to some others, because at least the complications are often not that life-threatening. So I think one of the things to be really aware of is that your post-op radiographs don't always look that pretty. And I've had cases that are doing brilliantly, and I've radiographed, and actually we used some of our nurses' horses and vets' horses for a thing, and we radiographed them after they'd had surgery, and they didn't look that pretty, even though they're doing really well. So I think that's where we are quite. It's not uncommon, I guess you would probably think this as well, where we have people that the horse has gone really well for a few years after its back surgery, and then they come back and say, my horse has been presenting with back pain, can we take an x-ray? And you think, oh God.
Fills you with dread.
Yeah, because you're like, I know this x-ray is not going to look that pretty, but that actually, I don't know what that means. That doesn't really mean very much.
Yes, I think this one we had recently, which was top right on this screen, which was, I think this is 4 years post minimally invasive ostectomy. And I think, not loads of remodeling, and obviously then even just a small either mineralization or fragment in one of those sites. This horse had no signs of back pain and was doing really well, came in for lameness and just took sort of a random radiograph of his back. So I think it's really hard to know the significance of this. But obviously if you saw this on a vetting, you'd be like, oh my God.
Yeah.
And then in terms of other sort of more short-term complications, infection rate, what do you?
I think the infection rate is probably, it does occur, definitely. I don't know actually what the rate is, but I think it's higher than some other clean surgeries, and I think there's numerous reasons for that. So it's traumatic, there's quite a lot of hemorrhage, it's got poor drainage. So I think those things all kind of do contribute. But when they get infected, I'm actually relatively relaxed. I warn owners that it might happen, and it happens in a minority of cases. But you say this might happen, and we're going to manage it, and then in the end it will be fine, kind of thing. So I think it can happen, but I wouldn't get too worried about it. And occasionally they can get little bumps along their back and little white hairs. I think the biggest complication is continuation of bucking behaviour, or as we've discussed, various of the studies have shown that lameness post-operatively is quite common. And I wonder whether that can either be that people have done surgery on lame horses, myself included, or actually also whether maybe horses have really subtle bilateral lameness that we're not aware of, even though we've tried to look for it, and then that progresses. So I think lameness is definitely one of the things that can occur.
Yeah, and I think we then also briefly mentioned the interspinous ligament desmotomy, and the picture at the bottom left is an example of the atrophy that can occasionally have.
120 horses, it only occurred in like 3 or 4.
Yeah,
so
so
it's
pretty
very
low complication rate.
incidence.
Yeah. So generally for most kissing spine surgery, the relatively low complication rate.
Yeah.
Great. So sort of wrapping it up then, Jo. So to cut or not to cut?
I think it's to cut with consideration. Which obviously I always do whenever I cut. But I think it's that, yes, I think it's got a good success rate, the surgery. I think that's where, and actually, to be honest, even in a case where I'm referred it and I'm like, oh, should I be doing this? I don't know whether, it's just had a radiograph, for example, and sent in without any other sort of assessment. I can fairly comfortably say to myself, well, most horses that I do this to get better in a mixed population that various people have seen. So it's, we got a reasonable chance to get better, and it's got a low risk of complications. So I think that I feel infused to cut, but I do think that we should be looking at the whole horse.
Yeah. Oh no, that's great.
Has anyone got any questions? I realize we didn't say, but you're either welcome to put them in the chat or turn your microphones on or whatever. I think we've just 4 minutes.
Perfect.
Time is not too bad. Silence.
If that's a good thing or a bad thing. Does anyone have any cases or anything they wanted to discuss, or any hopefully we've covered it all, Jo.
I had a question. I just wondered, given the sort of sensitivity of ultrasonographic evaluation of the articular process joints, do you still take oblique radiographs of those, or has the ultrasound replaced that?
I think we ultrasound more. Yeah, we don't tend to take the oblique shots as much, or hardly ever. I think sometimes if we see them on lateral images, but yeah, definitely less.
Mostly because they're really hard to take as well.
Yeah, sure. Yeah. Also wonder with the pelvic CT, how far cranially can you see along the caudal lumbar spine with that currently?
I think it depends on the size of the horse and the shape of the horse, actually, to be honest, as much as the size, but into the kind of caudal lumbar region. So you can see the caudal lumbar transverse processes and things, so beyond the SI joint. But yeah, Nadine is our star pelvic and lumbar CT, definitely, rather than us, I would say.
Yeah. But definitely the small horse, I think the 400-kilogram horse went in relatively recently, and we got sort of, I think, mid number. So yeah, no, it's a very exciting development, to be honest. But yeah, size of the horse is really crucial, I think.
Great, thanks.
Perfect. Well, if there are no more questions, we will sign off. But you're very welcome to join us for some more INGs over the winter period.
I think that there's huffings is next.
Yeah, and then we've got stickings going back to team orthopedics a bit later on, and I think then might be musclings to look forward to at some point in the new year. So yeah, I hope you guys have enjoyed it, and yeah, I'm looking forward to seeing you soon.
Okay, bye-bye.